Does anyone know when the first successful kidney transplant was in the world? And bonus points for where. If anyone knows, you can type an answer into the chat. I'll give you a minute or so for that, 30 seconds. You just have a rough guess. No one's put any answers. Yeah, 1968. Very good. So actually, the first successful one was in Boston between two identical twin brothers. And unfortunately, after about 8 years, it stopped working because of recurrent disease. I'm not sure what the primary kidney disease was, and you'd wonder with a twin, an identical twin, whether they might have the same condition as well. Yeah, that's how long ago it was. And does anyone know when the first children's kidney transplant was performed in England and where? We've had a Bristol. (1986) we've had. Pretty close. So actually it was at Guy's Hospital. So Guy's and St Thomas's was the first paediatric kidney centre in England. We now have 13 children's transplant centres across the UK, and 10 of those are transplanting centres. So the first paediatric one took place around 53 years ago in 1968, and an 11-year-old girl received her father's kidney. In fact, we celebrated the 50th anniversary a few years ago in 2018, and actually the recipient did come along there, but unfortunately some time ago now, and she no longer had that graft in situ. We also had someone who had a transplant around 40 years ago who still had the functioning kidney. And this shows just a table here. It's quite detailed, but you can see down the left-hand side all of the units that transplant, and you can see the numbers that we do per year. So if we look at the London centres, you can see Great Ormond Street tends to do the most across the UK, and Evelina, we tend to do about 20 per year. You'll notice that during the last year, the numbers dropped down because of the COVID pandemic when we had to pause the programme in the first wave. And so why might a child require a transplant? So this is a table from the UK most recent renal registry report, which was data from 2018, because now there's been a backlog with data analysis due to COVID. So looking back then, I mean, the numbers are fairly similar over year to year, with the largest proportion being CACUT, the congenital anomalies of the kidney and urinary tract, which is, for example, things like posterior urethral valves in the males. So over about half of the children are that group. And then you can see there's a split with other diagnoses, and there'll always be small numbers of children with Wilms tumour and other rarer conditions. So I'm going to move on to talk about transplant. You're all probably aware of the NHS Blood and Transplant Organisation, which is the organising body that governs transplantation in the UK. And it manages the on-call waiting list for deceased donor, but also looks after the living donors and collects outcome data for all recipients, both adults and children across the UK. In terms of kidney transplants, there's different ways you can get a kidney. So you can have a living donor, which is often from a family member, or it could be a living unrelated donor from a partner, or an altruistic donation from a live donor of someone that you don't know, or you could have a deceased donor. In terms of a deceased donor, then you go on call on a waiting list, and there's a priority, a special scheme that's very complex as an algorithm made, and then the patient gets allocated. We really want a well-matched kidney for a child who, we want it to last a long time, so to minimise the number of transplants through their lives. And then there's a national kidney sharing scheme, which has been in place over the past maybe 5 years or so now. And I'll go on to show you a diagram which explains that better. And that's a good way to get a living kidney, a live unrelated kidney. This is just a graph looking at the effect of the COVID. So we can't do a talk nowadays without mentioning COVID-19, and you can see a big drop down over the last year or so when the organ donors dropped and the number of people receiving transplants dropped. But pleasingly, if you look at the right-hand side of the graph, you can see that the numbers are already beginning to pick up now, which is excellent. In fact, we did 20% less organ donors overall for all organs during the COVID pandemic, I believe. This is explaining the National Kidney Sharing Scheme. So you can see if on the left-hand side a mother wants to offer a kidney, donate a kidney to her son, and another pair, maybe a husband and a wife, wanted to donate, but for one reason or other they're not a good match or blood group incompatible with their own person they want to offer to. So you can now put yourself in a pool as a donor, and you may be matched with another pair, so therefore you can exchange kidneys. And it could be a two-way swap, or it could be a three-way swap or more. So again, there's complex algorithms that work out how this would come about. And then it's obviously quite complex organising theatre lists across the country to let this happen. But it's a really good way to end up not going on a deceased donor list and ending up with a living donor. And you'll see why when I talk about outcomes later, why we might want a living donor over a deceased donor if that's a possible option. So our aim, where possible with children, is to do a preemptive transplant, so to preempt the need for dialysis, purely because of lifestyle and keeping them at school. We feel it's much better quality of life to go from being in chronic kidney disease prior to dialysis to then having a kidney transplant. It's not always possible because every year there's a handful of children that present in end-stage renal disease that need to go straight to dialysis from admission. And so therefore they then need working up over the next year or so for a transplant. And then there's other diagnoses such as congenital nephrotic syndrome, where ultimately there needs to be bilateral nephrectomies to make sure they're fit for the transplant and to allow it to be successful, or FSGS nephrotic syndrome, where they often have bilateral nephrectomies, severe hypertension, where we may remove the native kidneys, or Wilms tumour with WT mutations. In terms of the transplant workup, you can see it's quite a busy list, a lot to go through, as you'd expect, to put someone through an organ transplant to make sure they can tolerate immunosuppressants, to make sure that we can find a place to put the kidneys. The transplant surgeons and urologists are very involved because of the bladder and the drainage of the kidney. Lots of things, including seeing a dentist to make sure that they're not going to have problems with dental infections, having the immunosuppressants. And of course, it's a big undertaking for the whole family, so involving our psychologist and social worker in cases where relevant. In fact, everyone has a psychological assessment prior to transplant, and lots of education from the multidisciplinary team. Additional considerations are now we're seeing children with more complex past medical history, so children that may have had ex-prematurity, had a lot of respiratory support. Some children may be on oxygen at night or BiPAP now, and we've transplanted these children as well. Cardiac background, syndromic, children with learning needs, or it may be their parents with learning needs, which needs factoring into the post-transplant care because we don't want things to fail once they've got their valuable organ. We've had quite a few children with autistic spectrum disorder where we've had to get them really used to the idea of blood tests and the routine of coming to clinic and things, and work with even their schools to enable this. And some children have had a previous transplant that sadly failed, or they may have other organ transplants such as a heart or a liver. And we've had one child who's had a liver and small bowel transplant that we transplanted a few years ago. So I think our cases are becoming increasingly complex, which isn't surprising, I guess, if you think it's only just over 50 years since the first transplant was done and how medicine's evolved over that time. We look at the blood group, so ideally we like a child to have a blood group compatible transplant with their first transplant. Occasionally we do an ABO incompatible transplant now, but it's not our first line because there needs to be usually more immunosuppressants and the increased risk of rejection. So we'd often want to put, if there's a living donor that's not suitable or ABO incompatible, we'd use the kidney sharing scheme first and see if they go in a few runs of this, which happens every few months, and see if a match happens. And if after a year of having 3 or 4 runs we fail, then we relook at this and see if this is a possibility. In terms of immunology, we need to look at the HLA, the human leukocyte antigen matching. And I won't spend too long on this because you could almost do a separate talk in itself about this. But if anyone's interested, there's quite a good paper that one of our nurses has written to explain this and how we look at it. So I can always share that with people if they want me to. When we do this, we talk about a degree of match, and we score it with 1s or 0s. So a 0 means that there's no mismatch between the donor and the child for these particular 3 HLAs that we're particularly interested in. And if they have 1, 1, 1, it means that there's 1 of 2 mismatches. It's better explained on the next slide. So here, if you have a look, so the HLA loci that we're looking at are A, B, and DR. And you can see a mother's inherits 2 genes for each of them, and the father's got 2 genes for each of them. So a patient or their child would have 1 from each parent, and you can see there that they've inherited 3 from mum and 3 from dad. Therefore, they're a 1-1-1 match with each of their parents. And usually a parent would be a suitable living donor, but of course they may not be blood group incompatible, but they should be a good match. Occasionally the child may have made some antibodies against one of the HLA antigens their parents holds, and then it's not always possible for them to be a donor to their child. We have planning meetings before we go ahead with the kidney transplant, and again it involves a huge amount of the multidisciplinary team, including often these children with multiple comorbidities are very well known to their district general hospital teams, where they spend longer than coming to see us. So often we can now join in their local general paediatrician or their community paediatrician who may know the family very well and the child. We've talked about that. So in terms of size, it's often very challenging to grow these children in chronic or end-stage renal disease. And in our centre, our transplant surgeons are happy when we get the child to 10 kilograms. They also tend to look at how that 10 kilograms is distributed. So they also need a certain length as well. So the 10 kilograms is on the 50th centile for it should say a 12-month-old boy or a 14-month-old girl. In renal disease, in renal failure, it often takes they're nearer 2 or beyond to get them to 10 kilograms, because growth and nutrition is one of the things that we really struggle with in the chronic kidney disease setting. There's a picture here of a girl that was transplanted at Great Ormond Street, where the surgeons used some 3D printing to print her kidney, her dad's kidney, and print her abdomen, which is here, and to see how well they would fit in, taking into account her body shape and size. So you can see her vessels here, where they were going to go intra-abdominal to plumb the kidney, and her dad's very large kidney. You can see the livers here at the top and her pelvis, and it's quite a snug to fit it in. So in some cases they now offer this 3D print, and I think hers is on view in the Science Museum, which hopefully is now open. Here's some diagrams just showing where we'd put the kidneys. So in the smaller children, as I've alluded to there, it goes onto the aorta and the IVC via a midline laparotomy approach. And in the older children, above about 20 kilograms, it's a pelvic approach to extraperitoneal, and they have the classic hockey stick incision, usually in their right iliac fossa, but occasionally on their left if they've already had some surgery on the right, particularly as often bladder drainage surgery, that we often have a channel there called a Mitrofanov, so sometimes they prefer to go to the other side and avoid the adhesions. And then you can see the ureters usually plumb straight into the bladder, providing the bladder's safe to have the transplant. There we go, you see a picture. So some children now have 3 kidneys, they proudly tell us in clinic. In terms of success of transplant, then here's urine on the table intraoperatively, and the surgeons would definitely see this as a success, or the early days of success. And I think as nephrologists, we're always delighted when we see this plummeting creatinine. This is our most recent recipient who had a transplant in April, a living donor. You can see his creatinine started off at near 1,000. He was on peritoneal dialysis beforehand, and it rapidly plummets. So if you're on call that evening, you'd be very pleased with this. And his creatinine is now running around 50 to 55, which is great. But actually, it's the long-term care that matters as well, the adherence to medicines, all of the usual things with chronic illness. But the early days, we need to do a scan in recovery to check the graft's perfused, check there's no thrombosis, which would mean the graft could be lost within minutes if that was the case and not dealt with. The small recipients will go to intensive care, and children with any significant comorbidities that need additional support would go to intensive care as well. Otherwise, they come up to our children's ward. In the first few hours, you can see by the number of the dots on the last graph, lots of blood tests. So we're doing blood tests every 4 hours and looking at their inputs and outputs and really chasing their fluids to keep them really well hydrated. I've just listed a few potential early complications here. So we're particularly interested in keeping them well filled to avoid thrombosis and maintain their blood pressure. Often the kidneys come from an adult. Occasionally we have a deceased donor that may be from a child, but usually they're from adults. They're used to higher blood pressures than a lot of our children run. And that's particularly true of the very young children, where we often struggle to maintain a good blood pressure. So we need to really support the fluids, and sometimes they need inotropes. You can go the other way and get fluid overload and need to support that. And we rarely do use furosemide initially, but sometimes we have to. If you're not careful with the fluid, you could easily run into problems with pulmonary edema because we're pushing in often, 20 litres in the first day. With some of the teenagers, it can be huge volumes. And then we've got to remember simple things like blocked urinary catheters if suddenly the urine output drops, and surgical complications. So if via their drain it suddenly looks like some urine's passing, it's possible that there's an anastomotic leak. So we need the surgeons to closely be on standby. In terms of medications, the children all need immunosuppressants and to prevent rejection. And our protocol at the Evelina, at the moment, we follow a national standard immunosuppressant protocol, and there's 2 different protocols we can have, but we favour, where possible, the one with the rapid steroid wean. So we use tacrolimus and mycophenolate mofetil, and we use an induction agent called basiliximab, an IL-2 blocker. The children will have aspirin to prevent thrombosis for at least the first 4 weeks. Some of them need support with antihypertensive agents. Some children have valganciclovir for a CMV virus prophylaxis, and there's prophylactic antibiotics with cotrimoxazole for PJP pneumoniae. And it may be they have some for UTI prophylaxis as well, but usually the Septrin's fine for that. And they do need support with supplements sometimes, such as phosphate and magnesium, but some children get away without it. This is an example of a patient's dose box. You can see there's quite a few medicines there. We're always hoping that they'll end up being on less than they started when they were on dialysis or in CKD. I'll just quickly have a double check on the chat there. So post-transplant issues, here's a list of some of the complications. So occasionally, but more commonly with a deceased donor, you can have delayed graft function where the creatinine doesn't fall initially, and it takes time. Often it can take 2 weeks or more, sometimes even up to 6 to 8 weeks for the organ to get going, and you just have to hang in there. We always need to check it's not rejection by taking kidney biopsies intermittently. I've talked about some surgical complications like urinary leakage. You can get wound dehiscence as well, particularly in the smaller children where a relatively large organ is put into a small abdomen. Disease recurrence, a problem in some, particularly the FSGS nephrotic syndrome, which is a higher risk in certain groups. We're always on the lookout for that. You can get post-transplant diabetes, which is often drug-driven. The steroids and tacrolimus can lead to that, but often it's dietary, and there can be some genetic risk factors as well. Infections, which I'll mention later, post-transplant lymphoproliferative disease, and then other things like growth and development. We've transplanted them to hopefully improve their growth and improve their quality of life and their development, allow them to get to school. There's a lot of psychological issues that we see in our clinic all the time, particularly in the teenage years. And I think it's a real uncertainty sometimes, particularly the parents find that, not knowing what their latest results are and how long the kidney's going to work and so on. So we see these children really often at the start, but in fact COVID's changed that a little bit, because we obviously had to rethink how often we needed to see these children during the pandemic. But traditionally, a lot of their visits are face-to-face, where we examine them, we look at their fluid status, we check they're being adherent with both their medications and their fluids, we measure their tacrolimus drug level, we just see if they've got any complications of being immunosuppressed, because obviously it's a fine balance. You don't want to overdo things, but you don't want to underdo it and end up having organ rejection. We're always trying to educate them as well, particularly as they approach the teenage and young adult years, especially if they've had a transplant when they were very young and might not really recall anything about it, and their parents have been more or less doing everything for them. And we look at their longer term health as well, particularly their cardiovascular health, which is important into adulthood. So they often have ambulatory blood pressure monitor checks and echoes. But as I mentioned, in COVID, that changed things a lot. So now we have access to do some monitoring at home, and all the new patients are trained to measure their own blood pressures, their weights. Parents can check urinalysis as well. We can do video clinics. We've developed some blood testing methods, so we can get some samples posted back to the Evelina. So tacrolimus levels are quite lab dependent and variable. So if we run them in-house, then we can compare like to like when they come for their face-to-face visits. And also that's true of some of the viral loads. And then most recently, we've developed a finger prick test in collaboration with some other units to look at their creatinine and tacrolimus, and they can do that at home and post it to us. So that's very good for the more stable patients, or if we want to do a recheck between visits. So that's a bit more about the post-transplant surveillance. I'll go over that. So all of our patients as well, an important learning point is all the children have an individualized creatinine. So there isn't such a thing as normal range creatinine for a transplant patient, because this will change a bit over time. And also it depends on what their baseline is, where they start, have they had issues with rejection, where they've lost some baseline. So you can have a look at and see, this is a graph of a typical patient who runs a creatinine of about 50 to 60. And you can see that, so these are clinic visits where he's had at least 3 episodes of acute kidney injury. So on a good day, his creatinine is 50, 55, but then we have these sporadic ones. And in each case, it rapidly fell down, and it was to do with his adherence with fluids. And I think sometimes it takes a while for the families to understand the importance of keeping on top of drinking when their child's quite young. And it's difficult to be on their case all the time. This is just showing some common reasons why the transplant patients may develop acute kidney injury. When I think of AKI, in all cases, I always think of pre-renal. So are they having enough fluid, or are they having extra renal fluid losses, such as gastroenteritis? Is it a renal cause? Is there rejection going on? Have they been non-adherent with their immunosuppressants? So you get to know these patients and know, whether they've had such variable tacrolimus levels, or sometimes admit to us it's happened. Have they had any nephrotoxic medications, so accidentally taken some ibuprofen, or in an episode of sepsis, perhaps the gentamicins cause some toxicity. Tacrolimus itself and the levels it elevated can cause toxicity too. In the graft, it could be recurrent disease. So in some cases, you're always looking to see if there's a recurrence of proteinuria, so cases of Alport syndrome where they've been transplanted, and nephrotic syndrome. And then some of the viruses can affect the graft as well. And there's a virus called BK virus and also CMV. And then also the flow to the kidney, the vascular supply, is their transplant artery stenosis, which can cause an elevated creatinine. You might see that they've got an elevated blood pressure too. In terms of the post-renal causes, we're always thinking about obstruction. So is the drainage to the kidney optimal? So is there any problem with dilatation, which would be picked up on an ultrasound scan, and looking at their bladder management and bladder function? Or is there something extrinsic pressing? So we've sometimes had teenage girls where there's been an ovarian cyst that's caused some pressure there, or children that have had lots of surgery where there may be a stricture affecting the ureter and the drainage. In terms of signs of rejection, usually the most common is elevated creatinine, and they come to clinic and it's jumped up, and then we disclose some non-adherence there. It's rare for them to have some of the other signs, the weight gain, the fluid retention, tender graft. I think they'd have to miss a lot of medications before the graft got tender. So that's luckily, fortunately, doesn't often happen. The only way to diagnose rejection is on a kidney biopsy with histology. And this is a biopsy there where you can see these circular tubules cut in section. It's like cutting through straws, and there's nice cells. It all looks very compact. There's no big gaps in there. So this is a normal kidney, normal tubules there that you see. But we might pick up rejection. We might see infection, particularly the viral changes that we see with BK and CMV. Or we might find some tacrolimus toxicity and some scarring. Or we may find some dilatation or other features to suggest obstruction. In terms of types of rejection, there's a classification called the Banff criteria. We fortunately rarely ever see hyperacute rejection, purely because the clinical transplant labs make sure that there's no antibodies and that there's a negative cross-match before we proceed with the transplant nowadays. And more common is acute cellular rejection and antibody-mediated rejection. And this is an example of an acute cellular rejection. You can see the difference compared to the last histopathology slide where all the tubules were compact. This is just infiltrated everywhere with lots of lymphocytes, all these blue cells. It doesn't look healthy like the last one. And this was someone's kidney who responded to methylprednisolone. So the treatment is to pulse them with steroids usually, and often IV if they're within the first 6 weeks post-transplant, and otherwise we go for orally. Unless we suspect non-adherence, then we tend to keep them in for IV treatment. We also look at their background, find out why they've rejected. Is it purely for missing meds, or do we need to increase their background immunosuppressants? And then they obviously end up coming back to clinic a lot more once they've had a rejection episode. This is a young man who sadly took a bit of a drug holiday at the start of the COVID pandemic. He's a teenager, he was 17, and he just got to his first year post-transplant and was about to go to monthly visits, and those are the last sort of month, 11 and 12. And then just after 1 year, he came to a routine clinic and his creatinine had gone up, more than doubled. So he came in, had a biopsy, got pulsed with steroids and had plasma exchange. He had an antibody and cellular rejection. And you can see he's just lost baseline. We could never get him back as good as he was because he'd missed medicines for several days or even a week, a significant amount of non-adherence. So earlier on, I was saying it's a balance between managing rejection, preventing organ rejection, but also we want these children to live their lives to the full. So we don't want them constantly having infections because they're so over immunosuppressed. And again, we could do a whole talk about all the different infections that these children have and see. And I guess when they present locally to their A&Es when they're unwell, it's often with an infectious complication rather than the rejection. Some of these we'll just go over quickly. CMV often can either be primary CMV or more commonly reactivation if the donor was CMV positive into a CMV negative child. And we take the approach to give all these children 3 months of prophylactic antiviral valganciclovir. And at that stage, stop it when their immunosuppressant's a little bit lower. And at that point, we survey them. So every time that we come to clinic, we measure a CMV viral load during the first year. And then we can treat it again with treatment valganciclovir if needed, and often they respond to oral treatment. EBV or Epstein-Barr virus, the glandular fever virus, is commonly something that we see in the young children because most of them are EBV naive and negative for IgG prior to transplant, whereas most adults have acquired EBV at some point. So these younger children have primary EBV. Often they're asymptomatic and we pick it up on surveillance on their bloods, but maybe some of them have a lower grade viral illness, or some of them can develop lymphadenopathy and a complication called post-transplant lymphoproliferative disorder, which is exactly what we're trying to avoid. It's a rare complication, but it is a pre-lymphomatous condition and more common in the younger children. And because of this, when their EBV PCR levels are elevated, we want to lower their immunosuppressants and run it as low as possible without getting rejection. One of the red flags is if you ever see a transplant patient who's snoring with very enlarged tonsils, we need to refer them to ENT because we often want to remove those tonsils and get some tissue to check for PTLD. And that's true with any suspicious lymph node as well. So whenever we examine them in clinic, we always screen them for lymphadenopathy. So varicella or chickenpox, we try and make sure children are either have had chickenpox or are vaccinated, so they're positive for their IgG prior to transplant. And we're now checking their varicella status about 6 monthly post-transplant because some of them do lose their immunity. So then at least when they get a chickenpox contact, we can advise to take some acyclovir and plan that. They can't have the living vaccine once they're immunosuppressed, unfortunately, again, once they've lost immunity. There's a classic chickenpox. And then measles. So measles is interesting because we obviously have sporadic outbursts and it's never totally gone. And then I just looked up the data yesterday, and after the early part of 2020, there's really not been any cases. So you can see on the graph of the right-hand side, it's gone right down again, purely because of isolation and social distancing. Again, measles is a big problem for the transplant recipients if they got it. So if there's a measles outbreak at their school or locally, we'd advise them to stay at home until that's cleared. We've had a couple of cases of measles encephalitis quite a long time ago. So we really want to avoid them getting that at all costs. And again, all the children have the MMR vaccination before transplant, so hopefully the majority of them are immune. And then the other thing we commonly see is cold sores, and usually not as bad as the picture there, just 1 or 2 cold sores. And that's one of the things the families don't often contact us for, even though we do say that they should, to avoid it spreading. But all the children would need, rather than just topical acyclovir, they would need some oral acyclovir or valacyclovir treatment. And it's very handy often to swab the lesion, if possible, with viral swab to confirm it, partly because acyclovir is quite nephrotoxic. So if we don't need a prolonged course of it, we're keen to stop it. Again, I thought I'd just talk about COVID-19 in the in the infection section. And this is a busy table from NHSBT collecting weekly data on all the COVID cases in the transplant recipients across the UK and anyone waiting for a transplant or on dialysis. And this is just focusing on the kidney transplant patients who tested positive for COVID. And in the first wave, we isolated all of the children they were shielding. and because none of us knew, how things were going to evolve and what would happen. And we paused the transplant program for about 3 months and didn't do any deceased donors and cancelled the living donors that were scheduled. And that was quite different in the most recent wave, where we did have to pause living donors because of the adult ITU capacity was blocked, and it wasn't possible to do the living donation. And the deceased donors, we were able to carry on with those, although obviously the number of organ offers went right down. But you can see in the 0 to 17-year-old group, it's reassuring that 922 patients in total with a functioning kidney transplant. Of that 922, 48 were positive for COVID. Now, it may be falsely low purely because people were being careful and isolating. However, the ones that had it, we didn't have any deaths in that group. And you can see if you look lower down this chart, there's a lot more deaths in the older population. And there were 3 between the 18 and 29-year-old age group. So certainly something that hits the elderly, much more the older people. So therefore, we didn't shield the transplant patients, the young under 18s in the second wave. So outcomes. So I want to talk about outcomes now. This is a patient from a while ago now who's an adult who's competing in the World Transplant Games, who is an excellent swimmer. And I think this is really the great thing about transplants, that you really can live your life afterwards and, really be normal and achieve a lot. And that's what we really strive for. We don't do it if we think the quality of life is going to be poorer. So it's a lot to go through, but hopefully for good reasons. And in terms of outcome data, we will report to the NHSBT annually. And this is some outcome data, just a couple of slides on the living and deceased donors. So the most recent data, which was recently published. So this first graph is the outcome of the living donor kidney. So the 5-year graft survival is 91%. And actually that's higher than the deceased donors, where I think it's about 86%, it will say on the next slide. And you can see these plots, all the dots are the various units around the UK. So J is the Evelina. So along the bottom, it's the number of transplants. So the centres to the right are doing more per year. It depends on the population density. And then the smaller units are towards the left here. And you can see the average line there in grey, and it's a funnel plot. So I think all the centres are within the funnel plot there, but it just gives us opportunity to know if anyone falls as an outlier, then we can look into that as well. And the deceased donor, the 5-year graft survival is 86%. So that's why wherever there is a living donor, if possible, we're keen to encourage that. So I just wanted to talk about things to do with the acutely unwell transplanted child now. So now we've got a flavour of the background of what these families and children have been, and set the scene a bit. Really, when you see them acutely unwell in A&E or presenting, wherever it may be in your practice, I think the first thing is to treat them as any acutely unwell child in your usual approach. But there's a few caveats, I guess, that you need to look out for with a transplant recipient. And these are summarising them really. So fluids, medicines, prescribing, and other issues. So in terms of fluids, these transplant patients are so dependent on fluid. And if you remember back to that graph I showed you with a child with a few AKI episodes, his creatinine was normally around about 50. But, even being a little bit down on his fluid, I think some of those were where he'd been out for the day and he'd not drunk so much. You can see how much his creatinine more than doubled very easily. So actually, if they get behind, they can go into AKI very easily. All of our children have a fluid target set, which is often different to maintenance fluid. So it's kind of been set early on, and it does vary. We go through that each time they come to clinic, and some of them are better than others at meeting that. Some parents, maintain having a gastrostomy or an NG tube longer than others, and therefore they're kind of really on it with the fluids. But also the child also needs to learn to manage it themselves as they get older. And if they get gastroenteritis and behind, then that's often when they need additional fluids or a low threshold to give them some IV fluids. And so medicine. So look, we give them lots of medicines, as you can see. I think we've got one patient who's on 2 or 3 medicines, or a few that are just on their immunosuppressants only, but the majority have other supporting medicines as well. Such as blood pressure medicines. And one of the main interactions is with the drug tacrolimus. So there's a slide later which will show some of the common interactions with it, where the levels can be pushed up or down. We also need to dose adjust for their level of creatinine or their glomerular filtration rate, and I'll show you a formula to do that later on in the talk as well. We avoid any non-steroidal anti-inflammatory drugs, and usually the parents often will say it's almost an allergy sometimes, rather than one that we avoid. but occasionally they've not mentioned it and they've ended up going in, and because of pain, things had some non-steroidals and not really realised. We avoid macrolides, although azithromycin is the best one to give, but clarithromycin tends to increase, and erythromycin increase their tacrolimus levels significantly. And we tend to avoid trimethoprim, I guess, unless there's no other oral that's suitable for them, and that's because it pushes up their creatinine, though usually that's temporary, but can also cause some hyperkalemia. So these are the drug interactions to watch out for. We've mentioned the macrolides, the erythromycin, and then the antifungals are a classic one as well. So whenever we start one of these, we usually have to reduce their tacrolimus empirically. And then reduction of levels, so we sometimes have some teenagers that start the oral contraceptive and we have to do a time check of their tacrolimus after doing that in a planned way. It doesn't mean they can't, it just needs planning, and unfortunately some families don't always tell us, and then it comes in, they come to clinic with a low level. This is how you work out the glomerular filtration rate. So we use the height in centimetres. Times are constant, which for our unit's 31. In other centres it may be 34 or even 40, so it depends on where you work. But when we get rung for advice, we just say to use 31 and divide it by the creatinine, and that gives you their estimated GFR in mils per minute per 1.73 metres squared. And so some other issues is some atypical things is pyrexia. So sometimes a child might have a UTI or an illness but not be particularly pyrexial. And sometimes what we ask the families to do is if they hit a temperature of 38 degrees and it continues to call us for advice, and we have a low threshold to having those children reviewed. So if they have a 38 degrees and they seem well and it responds to paracetamol and doesn't rebound, we often just ask them to watch and wait. But if it continues or they're unwell, they need to go straight in for a review, or have a GP review if they can get one straight away. We have a low threshold to have rashes reviewed, and I think that's one of the common things families send to our nurse specialists and AMP to when they get a new onset rash, but often you need a face-to-face review. So we're very grateful for people seeing these children. Sometimes our families, being chronic and being sometimes medicalized, they can present late because they kind of don't, they spend so much time in hospital, they want to avoid it. We try and encourage them not to do that. And sometimes the urine dipstick, rather than if they're weren't immunosuppressed, you might see the full house of leukocytes and nitrates, but often these children might just have 2+ of leukocytes and a bit of blood, and then actually have a good going UTI there. So we have a low threshold to send it for an MCNS and start some antibiotics, particularly if they're a child who's known to have urine infections commonly. You can get atypical and opportunistic infections, and I'll show you some of those with the cases later. And sometimes prolonged infections. So sometimes some of the atypical pneumonias need a lot longer to treat them. So sometimes 10 days of the azithromycin as opposed to 3 days. Excuse me. So okay, over that. So for us, it's about good communication, both from us to all of you and back as well. Hopefully we're a fairly approachable team that can be contacted via switchboard very easily to speak to our registrar, or if not our consultant. We're trying to strive for all of our transplant patients now. We've got about 90 to 100 to have a named paediatrician at their local hospital, which usually works really well when it's set up, and it's really nice for the families too. It's where they go when they've got intercurrent illness, but also some of their other cares, their community care and so on, is at the local hospital too. And then to come to us for their in-between checks, their surveillance monitoring, and sometimes to transfer when they're acutely unwell. But a lot of children are managed at their local hospital now, close to home. We've talked a bit about having diarrhea and the importance of hydration and their fluid targets already. And I've talked about their urinary tract infections. I'll just double check how much time we've got here. So I haven't mentioned about abdominal pain. So this is one of the tricky ones because most of the children have the graft on the right side, which is exactly where the appendix is. So sometimes it can be very difficult to differentiate when they present locally with this. So we have a low threshold to involving the surgeons, both at the local unit and our transplant surgeons. So even if a phone call, because it actually, if you went in to remove the appendix, you'd come across the graft. So often we would transfer them. And I think it's often discussion surgeon to surgeon, depending on how unwell they are and what's possible. But occasionally they can have their appendix removed and it turns out it wasn't that, or it's thought to be graft tenderness when in fact it's appendicitis. So we'll move on to some cases. So the first case I've got is a girl who crash landed in renal failure. So her creatinine, I think, was like 600 or 700. She was a girl who was failing to thrive and quite sleepy, and then had a routine set of blood tests and showed she was in renal failure. So came in and was diagnosed with subsequently nephronophthisis, which is a genetic cystic kidney condition. And children often seem to present in end stage with this. She started peritoneal dialysis and then subsequently had a transplant from her mum a few years later. And she was on a different immunosuppressant protocol back then, where we used azathioprine rather than MMF, although she was subsequently switched to an MMF-based one because she had some tacrolimus toxicity to enable us to reduce her tacrolimus dosing. Anyway, she was fine, really, rarely ever in hospital at all, just in clinic. And then she went swimming one day in the Thames and developed a severe gastroenteritis. Let me see, sorry. So she came to clinic, and you can see where she spikes her creatinine there in the October visit, and a very, very high tacrolimus, because diarrhea can change your intrahepatic absorption of tacrolimus and give you very, very high levels of it. So that's why we have a low threshold to review these children as well and get an early tacrolimus level. We got microscopy and stool sent on her, and it turned out that she had cryptosporidium and needed a course of this nitazoxanide. I think children without immunosuppressants can often get over this, but in immunosuppressed, we had to give her this treatment and watch her. Luckily, she made a good recovery, although you can see her creatinine didn't ever quite go back to where it had been before. Another case that may present, so a boy who was 10 had a renal transplant a few months prior, and he was also on dialysis, peritoneal dialysis beforehand, for an atypical form of hemolytic uremic syndrome. We can see his drugs there, so he's on some immunosuppressants, but also 2 blood pressure agents, Septrin and some magnesium supplements. And a call went through to one of our nurses, and his mum was saying he's not been quite right and felt a bit tired, so was a bit more sleepy, and complained his eyes hurt in the light, and he had a headache, but then he was sick and felt better. His mum actually, because they did peritoneal dialysis, a lot of these families can measure blood pressures, and she checked his blood pressure. It was 90 to 100. It's not particularly high. It seemed fine for his age. And then he got another episode of his headaches and his eyes hurting the following day. So at that point she rang. So the day before had no history of fever. Does anyone want to put in the chat what they think might be going on, or a differential, or what you'd want to advise this mother? And does he need to be seen, or can we wait it out? I'll give you a minute or so. I've done lots of talking. What would you think if this child's immunosuppressed? Yeah, so someone said needs to be seen urgently. Absolutely. I think we would have sent them in the day before had we known. Do you think of any differentials? Yeah, excellent. So we're all in CNI infection, exactly. Meningitis, brilliant. Is there anything else? Great. No, that's definitely at the top of your list, isn't it? So actually, sometimes the families are quite difficult to persuade to come in because, like we said, sometimes the immunosuppressants often masks them being more unwell, so it's quite hard to persuade them sometimes. So again, this mum said she was about to go swimming and she'd given him paracetamol, and we're just wondering whether they could come to the day unit instead the next day, because often they find it more convenient to just turn up when someone's expecting them. They don't often want to go to A&E. So it's hard, and it's always much easier when we've got a good shared care set up. Anyway, they did come in with some persuasion. He was afebrile, the headache disappeared. He was given some codeine because he couldn't have Nurofen. His examination appeared to be okay, but they couldn't see his fundi when we asked. It was difficult. He'd had some blood tests. His creatinine looked okay at 58. His white cell count doesn't look particularly startling. The only protein on the urine dipstick. I can see lots of people are putting about encephalitis meningitis, and I think we'd certainly want to give him some cover, wouldn't we, and do some more tests. So they got an ophthalmology review, and he had bilateral papilledema, so ended up going on to have a CT to look for a mass given the immunosuppressants. Unfortunately, he didn't have a mass, and he subsequently went on to, he was transferred across and had an LP with a very high opening pressure. So he had idiopathic intracranial hypertension. So his pressure was 56, so huge, and we reduced it down to 20. I think I ended up doing the LP with a neurology consultant there, and we had to get like the double stack manometer together. But luckily there didn't seem to be any signs of CNS infection, although he was covered for that until we had everything back. He was treated, so his prednisolone got reduced because it was thought that could be a factor in this, and he started some acetazolamide to try and reduce that pressure too, and ended up having close ophthalmology surveillance because he also had, when you mapped out his blind spot, it was very enlarged, but he made a really good recovery, fortunately. And then another case is of an 11-year-old boy. This boy actually just came to routine clinic. I remember it well because it was my birthday on the day he turned up. And so he was about 9 years post-transplant then. He'd been transplanted when he was just under 2 with the dysplasia. He was a preemptive transplant from his mum and had a baseline creatinine of about 75. So he was doing very well with his long-term follow-up, but he had a 3 to 4 week history of a cough. It was the first we knew of this with some white sputum. By this stage, they only come to clinic about every 3 months, so you wouldn't necessarily pick this up unless they rang. Only missed 1 day of school though, so I suspect they thought he wasn't too bad. But actually, when you took the history, he was hot at night. He was often slumping on the sofa after school, quite tired. He also had this history of a rash on his back from 2 months beforehand and had lost weight for about 2.5 kilos. The family had been traveling to Cuba, and you could see he's got a low blood pressure of 66 systolic, although he was afebrile, no obvious lymphadenopathy. Examination, his chest sounded clear, no hepatosplenomegaly. This is his skin rash here. So it looked all old and scarred, and we weren't particularly sure what this was. And this is his chest x-ray, where you can see he's got nodular infiltrates bilaterally there. Can anyone think of a differential diagnosis for him, or what might be going on? Because I think there's a few possibilities in his case. I think, yeah, very good. So PJP, PTLD, because actually it does sound like he's having night sweats and this weight loss. So I was concerned he might have PTLD. What about any other opportunistic infections? So most of our patients have had a BCG or screened to make sure that they haven't had TB, but I guess TB could be a possibility as well. So he went on to have a CT, which you can see there again, all the infiltrates there. It's very abnormal, and there's also some lymphadenopathy, hyalulymphadenopathy. Yep, sarcoidosis. Yeah, we certainly screened for a lot of things on him, and one of the things that happened, we asked dermatology to come and see him, but his skin just looked scarred, and they weren't really convinced they get anything from it. But after a bit of persuasion, he did have a skin biopsy as well, and we were interested because of that history of him going to Cuba, whether he had something that he'd acquired there. So actually it was his skin biopsy that initially made the diagnosis and isolated some histoplasma on it. So the turquoise stain there in the upper right. Unfortunately, the chat's masking my slides a little bit, but within there they could see the histoplasm. And we did a kidney biopsy where we saw a granuloma, a partial granuloma that we'd clipped, which they also thought was an organizing area where showed evidence of histoplasmosis as well. So he had systemic histoplasmosis because he had respiratory involvement as well. So actually he's very lucky he wasn't sicker than he was. And he ended up on Ambazone for about 4 to 6 weeks. We had to lower immunosuppressants in his case as well. So he ended up with some rejection and needed steroids and immunoglobulin. But fortunately, we've transferred him to adults now just in the COVID pandemic. He's 18, he's at university, and he made excellent recovery. His creatinine is about 150, and he does have some chronic antibody-mediated rejection. But overall, he did better than we expected, and he's now on lifelong antifungal prophylaxis because this can lie dormant. And so really my summary is, I think we've got a few more minutes. So even when a transplant patient seemingly well, sometimes like when you probe more, they're not. And we always have to have a few things in the back of our mind that they're at the risk of more rare opportunistic infections. But even common infections like urine infections can present atypically, and they can get complications of their immunosuppressant at any time along their course. So even if they seem to be the most stable patient at 10 years post-transplant on 3 monthly reviews, suddenly something can come out of the blue. And therefore we do have a low threshold to reviewing these children if they're not quite right, if their parents say that, or they're not tolerating their fluids. That we do advise that they go in, and we have a lower threshold to investigate, really. And the few red flags, just to recap, as for any presenting children, all the usual things, but hydration, trying to avoid the acute kidney injury in their case, because then it's much easier managing them. When they go into AKI, it becomes very difficult when they're oliguric and have to alter all their drugs. Remember, they've got individual fluid targets. Some of them are a lot more polyuric than others, because some of them have native urine output from their non-transplant kidney as well. There can be lots of drug interactions that can occur. We need to dose adjust their drugs, avoid the non-steroidal anti-inflammatory drugs, and macrolides, which are two of the common ones we do tend to use otherwise in children. And we tend to avoid trimethoprim as well. So my take-home message really is that you can see the transplant's a treatment and by far the best form of renal replacement therapy, but it's not a cure. And that's a common misconception, I think, sometimes when we see how easy a transplant is in some of the soap operas or dramas on TV, they almost go in and out the same day having their transplant, and there doesn't seem to be any workup or any follow-up. But these don't last forever, and I think sometimes that's really shocking to the families, and sometimes even the teenagers transplanted when they were young children haven't realised that. So psychologically it can be hard at times too, but we do it to make them live their lives. Like the swimming boy, we've got a number of children who are excellent at sports and now gone off to adulthood, university, great achievements, and really not being defined by all their time in hospital, which is really nice to see. The immunosuppressant brings a whole host of different issues and keeps us on our toes. And as I've said, we have low thresholds for treatment and admission and reviews for these children. We know that they're going to be on lifelong medications with their renal disease. So we have to build up a really good long-term relationship with the whole MDT. And I think it's real uncertainty that they live with at times. And I think that's one of the things that the parents really struggle with, sometimes more than the children. So I want to say a big thank you for listening. I know I've done a lot of talking. This boy, I kept this card because I thought it was so sweet, but he's like, when he was 14, he looked about 18 and he was transplanted, I think, when he was about 9 or 10, but I loved it. Thank you for looking after me, even when you stick needles in me, which is very true of renal. We're always obsessed with bloods, aren't we, as you'll know. I thought it was nice. And the LSP just said to put the QR code there if you want to do any feedback. Anyway, that's a bit of a kind of flash tour of transplant and give you a flavour of what we manage day to day in our world and jobs. If anyone wants to ask me any questions, I guess either you can unmute or put it on the chat there. And if there's any bit that you're particularly interested in and want me to do a bit more of a detailed talk, I'm always happy to as well. I can also put my email, if you like, on the chat, because if anyone wants to come down to Transplant Clinic and join us at any point, we often do have visitors coming. So if you kind of email and book in, we can do that. We just move the chat now so I can see it a bit more. Do you cite central lines? So this is a very good question, because we've got a child coming up for transplant who is extremely needle phobic and he has a Hickman line in. So we really try not to, because of the risk of infection with the plastic there. And we have children sometimes where they're quite needle phobic, or they've got incredibly challenging veins. And so sometimes in the children with the dialysis access, we use their tunneled line, but at the time when they have a transplant stent in their bladder from their kidney anastomosis down, and at 4 to 6 weeks we remove it, and we try to take out their central line at the same time, usually, because it's just such, if you get a line sepsis and then have to withdraw immunosuppressants and then rejection, you end up with a whole host of other issues. So we're at the moment having a bit of a team debate about what to do with our patient who's very needle phobic, and I've asked like the national groups, because we work together quite closely, has anyone had any children like this with ports or so on. We've got one boy with a port now, which we put in post-transplant because he was so difficult. When he was ill, he ended up with an IO needle to get fluids in and things, so he's the only one, but he's now ready to have his port out. And then another question says, does the kidney not last forever just because it might not be completely matched, or is there something else about the transplant process? Which means, yes, so it's to do with, because unless you're an identical twin, you're going to be genetically different, and so therefore, although we look at 3 particular HLAs in the matching, but there's a lot of other HLA antigens that they do look at, but they're not reported in the mismatch score that we do, and therefore over time you're going to need immunosuppressants, and some of them, like tacrolimus, is nephrotoxic. So over the years we do expect a bit of a decline of GFR because of chronic allograft nephropathy or chronic antibody mediated rejection. So unfortunately they don't last forever unless you're an identical twin. Although in that first case ever, it sounds like the person had recurrent disease. So I guess if you're an identical twin, that could happen if they've got some sort of antibody-driven disease that comes back. But we've got many children who go to adulthood with a creatinine under 100 and do really well. And one of the first patients I looked after, he was a toddler. He was under 2 when he had his transplants, and he's now about 25, 26 with the creatinine under 100, just on 2 immunosuppressants. And we hope that kidney will last a long, long time. So that's why in children we want to go for a really good match. And in the deceased donor allocation scheme, the match is prioritised so much. So in a child, we can score what we want to put them on for. So we would only accept a very well-matched kidney unless a child's struggling with dialysis access and going to die because of loss of access. Then we can't be so picky. Oh, thank you for the comments, everyone. It certainly is a niche area, but I think it is, like, there's lots of principles that apply to other children with renal disease and other children, and so hopefully that's helpful anyway. And hopefully I've sparked some interest, and maybe a few of you will come and meet us in transplant clinic. So if you ever want to or have a bit of study leave, please do. I'll just put my email here, because it's a hard one to guess because I've got this number 1 in it.